function in the phase 3 clinical trials.
So today I would like to talk to you about Pegcetacoplan therapy in geographic atrophy, therapeutic effect on retinal pigment epithelium, RPE, and photoreceptors, PR, integrity and function in the phase 3 clinical trials. So first thing we need to do if we want to approach the RPE is get out of this 19th century FAF black hole and really understand where the RPE is missing based on an OCT, because the OCT offers the opportunity to follow the RPE in all its extensions. That is a way that has to be taken seriously, so we perform manual annotation, large scale, to provide enough ground truth, and then we trained an automated segmentation algorithm, and then we had to take the step from FAF to OCT to show that the lesion size was really consistent. First step, so that it will be allowed for me to talk about RPE later on. How about photoreceptors? That is a more tricky path, of course, as the photoreceptors are not clearly visible. So we designed an algorithm that is an ensemble algorithm of 4 nets that were put together and on an A-scan level allowed us to identify photoreceptor absence, alteration, and also thinning. So this is an extremely precise algorithm that really focuses on the photoreceptor layer, not like other algorithms that go straight through the EZ line and straight through the RPE because it's a broad band, but really from the top of the EZ line down to the interdigitations of the photoreceptors. So very precise on a pixel level. Now that we are equipped with such precision tools, we could look on the phase 3 trials, which was OAKS, as seen here. The gray line is always the sham line, and red and blue are monthly and bi-monthly treatment. You can clearly see that in OAKS, at the level of the photoreceptors, the gray line, the progression of the disease, is much lower than the progression at the level of the photoreceptors. So this is a neurodegenerative disease that starts with the photoreceptors. But pleasantly, you can also see how much effect the treatment had on reducing that progression. So the blue and red lines are much below, and the effect is most impressive at the level of the photoreceptors. You can see that 53% inhibition as compared to 22% inhibition. The same was found in Derby. Again, you see very consistently photoreceptor degeneration moves fast, RPE, secondary RPE loss happens much slower, and the effect on both layers is different in terms of intensity, 27% at the level of the RPE layer, 47% at the level of the photoreceptors. So this therapy is very efficient at the level of the photoreceptors, which is the correlate for function. How can we imagine that this looks like? So we picked one patient who has disease in both eyes. I remind you that the red area is always the black hole on FAF, it's the RPE layer, and the green area is always the photoreceptor changed. So this patient's untreated fellow eye on the right side progressed very fast. You can also understand how GA works. It really starts with the photoreceptor alteration, which is then followed by the RPE loss. And look on the left eye, which was treated, how much slower the progression is, particularly at the level of photoreceptor degeneration, which also keeps the RPE lesion small, and here can also maintain the fovea. So the same thing could also be reproduced very pleasantly on the long term when lesions were larger. So this is the crossover at the end of the phase 3 studies when all the sham patients were then treated. And you see that even larger